Women athletes are more likely to sustain a concussion during sports than their male counterparts. Stay tuned because today you will discover the impact of head and neck injuries on cognitive function in women, including an understanding of the mechanisms of injury, hormonal changes, and the common cognitive deficits that can result. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions to recover from head and neck injuries and to improve neurologic functions for your patients. I'm honored to welcome our next guest expert. Dr. Habanova is a chiropractic neurologist with a unique background in clinical neuroscience and functional medicine. Her passion for women's brain health and personalized medicine has led her to focus on helping high achieving women enhance their cognitive fitness and become cognitively unstoppable. Today, she'll be sharing with us the impact of head and neck injuries on women's cognitive function and overview. Dr. Habanova, thank you so much for joining us today on the Virtual Neurology Summit. Please take it away.
Welcome, everyone.
Good.
Today I'm going to be presenting on the impact of head and neck injuries on women's cognitive health, a very unique niched area where there has been some wonderful revelations, understandings, and new developments with the latest technology and neuroimagery that has been improved over the last several years. So exciting to share this information with all of you. Dr. Burns has done a beautiful job of introducing me. So Dr. Habanova here, board certified chiropractic neurologist, and I have the privilege of having a virtual women's brain health practice called the Palm Beach Brain Center here in Florida, as well as being a clinician. I enjoy being an educator as well as a speaker and presenter at wonderful events like the Virtual Neurology Summit. Today, what we're going to cover is a little bit of just some basic introduction, understanding the prevalence and rates of TBIs among women as well as male. In the male population, not just in athletes, but in overall, so we can understand sort of what is occurring there for women's brain health when we or they sustain a head or neck injury. We'll go into some mechanisms as well as the hormonal changes that occur, which is a major player. So that's important to understand the components of that, as well as some things to think about when you're diagnosing and treating head and neck injuries in women in your practice, and how to preserve some of that cognitive function so that you can continue to create and improve that woman's cognitive reserve and resilience moving forward. But before we kick in, I really would like to just take a moment and honor this one thought, because it's really important for when women are seeing physicians about head and neck related injuries. When they're talking about cognitive health, there's still somewhat of an undiscussed hush kind of tone that occurs in the practice. And honestly, really a food for thought would be just being receptive to listening to your patients, obviously male and female patients, particularly to the females when they want to discuss some of those cognitive changes that are occurring. And that would just be a beautiful act of service to your female patients. And we'll talk about that a little bit towards the end as we get into patient management and how that plays a huge role in outcome to their abilities to recover a lot faster. So just a quick little introduction and overview here, just so that we all can be on the same page. Looking at some prevalence and impact of head and neck injuries in cognitive function in women. There was a really wonderful study done. It was actually in a workshop style event in 2017 called Understanding TBI in Women. And this was actually put together by the National Institute of Health in partnership with the Center of Neuroscience and Regenerative Medicine, as well as the Defense of Veteran Brain Injury Center. So there was a couple, three big players that came together, and they wanted to really focus on the unique challenges that researchers and clinicians, as well as patients, were experiencing, and looking for any gaps that might be occurring in the TBI space, particularly related around women. So a really fascinating study was done there. And basically some of the high points from that is, clearly highlight that women have been underrepresented in any type of TBI studies as well as clinical trials. So of course that is changing, but up to that point, there has been that underrepresentation. And that what was really interesting is that, it showed that human studies reported worse outcomes in women over men than did animal studies. So a lot of times, again, they'll be using rats and things like that to try to understand that. And interesting enough that the female rats did better in TBI outcomes, but when they crossed that over into human studies, they found that women actually had worse outcomes than men did. And that's something really important to think about when you're reading your own research and looking through the literature to take that into consideration. Why don't we take a moment and look a little bit about the rates of the outcomes of TBIs in across the sexes, across different lifespans. So starting with pediatrics, young males tend to be about 2 times more likely to sustain a TBI than young females, predominantly because of their risky behavior. They're jumping out of trees and off of fences and things like that. So they're just, making various decisions in their risky behaviors that young females tend not to do. But interesting enough that when a young female did sustain a TBI, she had a longer hospital stay than her young male counterparts did, and tend to move towards worser outcomes. And you're going to see that as a continuous theme throughout the different milestones in the lifespan. Looking into adolescence here, we're going to see that the concussion rates are actually higher among females than males with same-sex matched sports. So once again, longer recovery time in female athletes, but with a higher baseline rate of symptoms reporting. So, if they're going to say that they're feeling dizzy, it is rated at a higher scale than, let's say, their male counterpart would say they were dizzy. So all the symptoms seem to be more exacerbated at baseline. In the adult population, what's interesting here is a recent study looked at about 90,000 individuals with a concussion and found that a neck injury had a comorbidity was significantly higher in females. So seeing again that head and neck injury combination more prevalent. And that highest rate was seen between puberty and the onset of menopause. So here again, we're starting to paint that hormonal landscape. Is there some contributions going on to how there may be the variations in various hormones throughout the female cycle between the onset of puberty and menopause? Most likely that's the case there. And again, going into the adult population, another study was looking at 700,000 people, so both male and women that were hospitalized for TBI, followed over a period of time. It showed that there was a greater risk of dementia with a comorbidity of a spinal injury. Again, seeing that early onset dementia with females. And again, we're going to start to see that theme as women are starting to experience any types of brain injuries. There'll be this increased risk of an early onset of dementia. In the aging population, it gets interesting because the rates of a TBI hospitalization are actually similar, but the females over the age of 65 were found to have a higher diagnosis of a mild TBI. And maybe that's because they're reporting it more often, that there are some, things to consider, some factors when looking at some of these statistics. But what was interesting is that regardless of it being reported or not, the older females were more likely to be institutionalized after hospitalization for TBI. So again, there's more of a compounding effect for women undergoing head and neck injuries, and how those outcomes are playing out. Something I thought was actually really interesting as doing some of this research is that there's so much more information coming to the table for intimate partner violence. More research articles are being written about it. And I thought this statistic was interesting because it's incredibly high, that 94% of injured women sustain abuse from the neck and higher. So it's an interesting population to be studied. And it was showing that the brain injury scores were negatively associated with measures of learning, memory, and cognitive flexibility. Data is also showing that some of the damage occurred through intimate partner violence may not just be persistent, but may actually be permanent as well. So again, a little bit more of a recent field with more information coming out, but definitely fascinating. And 2 neuroimaging studies examined the effects of intimate partner violence, IPV, related brain injury, and concluded that there is definitely deleterious effects to women's neural and cognitive health. And lastly, in the military, more women are becoming involved. Blast injuries, we know, definitely create a concussive-like response, similar to a sports concussion, for example. But unfortunately, there are not a lot of studies that have allowed women to be a part of those research projects. So again, very limited and small number of participants. So hopefully in the future that will open up. But that's definitely an area still to consider with any type of military interaction. So more or less, as a quick summary here on this slide, we know that TBIs are a major cause of lifelong disability and mortality. Definitely, we know that it becomes a risk factor for neurodegenerative diseases such as Alzheimer's, and that women tend to, have more symptoms initially after the concussion. These symptoms tend to persist for longer. There is definitely greater post-concussive deficits seen between the females and males, higher risk of early onset dementia, higher degree of hospitalization or institutionalization after hospitalization of a TBI, and then that possibility of permanent damage with intimate partner violence. So things to kind of think about as you're working with your patients and having a woman come in with those head and neck injuries. Those are the areas that you're going to want to be focusing in on. But if we want to address particularly cognitive impairment following a mild TBI injury, this was a study done with a Brazilian population, and they actually looked at both sexes in this study in 2019 in the Frontiers of Neurology. And they were looking at cognitive function. They assessed it as a mini mental status examination. They also were doing a frontal assessment battery test, which is more predominantly looked to help differentiate frontal temporal dementia, using digit span for working memory and vision memory tests as well for that episodic memory. And what they were really showing here is that they're seeing definitely cognitive changes at the acute phase, but as well as 6 months into the follow-up. And particularly some of the areas here would be immediate memory, learning memory, delayed recall, episodic memory, executive function, as well as visual and verbal memory related issues. And upon neurophysiological measures in the acute phase, they definitely saw significant changes in the axons, so in the white matter integrity in particular areas. So here it's really becoming interesting to now be able to delineate down into what areas are being damaged. And from this study, they were showing that in particular the splenium in the corpus callosum. So if you remember, the corpus callosum is that horizontal white matter tract that connects the right and left brain together. The splenium is that posterior part. It's the thickest and most back part of the corpus callosum, and it is going to contain a lot of connections between both temporal lobes as well as the parietal occipital lobes. So it's going to be involved in things like visual spatial information, transfer of language, reading, even calculations, math calculations, IQ, and consciousness. So it plays a pretty critical role. They also saw that there were issues in white matter integrity as well as the cingulum. And again, the cingulum, another important major white matter tract that's connects more the frontal lobe and the parietal lobe with the temporal lobes on both sides. And this will be more responsible for memory information. Many times when the cingulum is affected as well, we'll see issues with the not the hypothalamus, the hippocampus, with the hippocampus where we're going to be storing an important area to store memory. So again, we're seeing a lot of these cognitive related functions and kind of all over brain influences with the effects there with the axon sharing. And we're also seeing that, we're seeing some gray matter morphological changes. So it's clear that we're definitely getting brain structure changes. Again, this is on high resolution neuroimaging. So something you're not necessarily going to see on a regular MRI in terms of structural damage in that way. But from a functional perspective, it is clear. And lastly, one other area to consider here is another area where they saw disruption in white matter integrity would be in the ventral prefrontal cortex. And this area comprises of a variety of distinct areas, but it's key in supporting decision-making processes. It's also part of the default mode network, so it becomes a critical area to consider. This is really important in terms of being default mode networks important in being active during the resting state and when there's some mind wandering going on and through there. So let's take a moment here and take a look a little bit more at some of the molecular mechanisms that occurs in head and neck injuries. And I really like this little chart here because it really kind of helps you walk through some of the major consequences of when we look at cognitive dysfunction as the final outcome or output, we can really see that three distinct areas are responsible for that. So however that initial injury occurred, either we'll have that focal or a diffuse response, and that kind of just shuttles all over here to the secondary cellular injury mechanisms. And here we're seeing that exocyticity, we're seeing an increase in calcium overload, we have the axonal shearing, we're changing the polarization of the membranes, a lot of oxidative stress, mitochondrial dysfunction. So now their ATP production is altered, and of course, an inflammatory response. So all of that basically can lead to either axonal degeneration, or possibly even just cell death completely, or there can be synaptic dysfunction. So all of that, not all of it goes to one direction. There's going to be a combination between the three possible outcomes, and that will sort of present that cognitive dysfunction palette per se of what that person will see. So the extent of cell death and axonal injury strongly correlates with the neurological outcome of the TBI. What we're really seeing is a decrease in long-term potentiation and an increase in long-term depression. So that's the most important thing here as a clinician, recognizing that aspect occurring and then trying to balance out those scales. Now, overall, in terms of common deficits that are seen specifically in head and neck injuries in women, again, we're going to see a greater number of them. So a greater number of deficits, a greater severity of those deficits, as well as a greater duration as post-concussive syndrome. So these are most likely the symptoms that your patients will be presenting in. And these are definitely things that you might want to ask for in a screen, or have some maybe intake form that you want to review this. Perhaps you're going to use these as outcome factors as well as you're measuring the progression of your treatment plan to ensure that we're seeing improvements and changes in through here. So those will be the big areas of focus. And specifically with cognitive function. So if we want to drill it down a little bit more in detail, where neurofatigue is really the top of the list there. So brain-based fatigue. This is where we're going to see that reduced information processing speed, attention deficit, learning and memory, visual, verbal learning, recall, recognition tasks are going to be exhausting and fatiguing, will be delayed. Definitely impairments of the executive functioning, so planning, organization, problem solving, lack of initiative or motivation, a lot of inflexibility, like cognitive inflexibility or limbic inflexibility, ability to shift gears basically will be impaired or delayed. A lot of times, difficulty self-monitoring, maybe socially inappropriate. So a lot of frontal lobe related findings. Word finding challenges, difficulty following conversation, again, are large, as well as those changes in mood. And again, difficulty adjusting, that limbic flexibility mentioned earlier. So again, if you're going to be using this as a gauge to determine if some of your female patients are experiencing any of these would be the biggies that you would want to review and highlight. So let's take a moment here, take a look at some hormonal changes, because that has significantly played a role, definitely puberty to menopause. And then, if there was a concussion that happened postmenopausal or in the menopausal transition, how is that going to look like? So just a quick review of the hypothalamus, the pituitary, and the ovary axis, so the HPO axis. So we're going to have the hypothalamus release our gonadotrophin releasing hormone into our anterior pituitary, luteinizing hormone, as well as follicular stimulating hormone will come down into the actual ovary, create and stimulate an oocyte to move into the second phase of meiosis. And then we're going to have estrogen and progesterone release, and we'll have those negative feedback loops. So if we take a look at that process occurring, but take a look at it over a woman's monthly cycle, so from day one all the way to the end of the month, we can see that there is hormonal fluctuations throughout the month. And we can see that we've got a follicular phase as well as luteal phase. But we can see here that there's definitely changes in hormonal levels. So quickly, we'll just take a look at the estrogens. We can see much higher pre-ovulation and then lower after. And then progesterone kind of does the opposite in a flip-flop. And overall hormonal levels here, we can see that in the follicular phase, the hormones are much higher than they are in the luteal phase. So various things, women are going to have better spatial skills in the follicular phase. That might cause more anxiousness because they're more aware of things, because they're more spatially aware of what's going on. But they're going to have improved imagination, perception, memory. And then when progesterone's higher in the luteal phase, they're going to be a little calmer, tend to have more sexual desire. But they also are actually not as good at recognizing fearful situations, and have poor skills. So sometimes it can make, maybe poor decision making in there. Dr. Burns, am I okay just to finish off this section? Because I know I'm running just a little over time, but okay,
Yeah,
this part's really
absolutely.
important. So I
Yeah.
just want to wrap this part up, because what's important is when you're working with your female patients, the timing of that head and neck injury in terms of her cycle is critical. So again, if we're just going to look at our little chart here, what they show is that what happens when a woman has that injury in her follicular phase versus the luteal phase, what happens, and there are significant differences. So what's called the withdrawal hypothesis is that it's postulating that if a TBI occurs while progesterone is high, so in the luteal phase, even though it is known that high progesterone is neuroprotective, but if a TBI occurs in this phase, there is a sudden drop or decrease in that progesterone level from being really high because of the brain traumatic event. If there's going to be a shunting of that causes worse outcomes for women compared to male counterparts that have relatively consistent and low progesterone through whole cycle. This is also compared to women who have a concussion in their follicular phase. So basically, this is what this whole little section is saying, that women that are going to have the concussions in the luteal phase, because of the high progesterone, concussion happens, drops to low progesterone very rapidly, very suddenly, that causes worse outcomes. So if we're just going to be looking at that, and I'll kind of wrap it up and through here, if we're going to be doing some diagnostic evaluation and determining our treatment plan for helping women with head and neck injuries, one of the things you'll want to definitely consider is either doing a serum testing. You might want to evaluate the test levels, or maybe just ask them about their menstrual cycle. And again, it's those women in the luteal phase that tend to do worse. Women in the follicular phase tend to have better outcomes. And women who are actually on birth control throughout the whole cycle, doesn't matter if she had the head injury in the beginning of her cycle, in the middle of her cycle, the thought that she was on birth control and on consistent amounts of progesterone, she actually does just as well as women in their follicular phase in regards to that. Just a couple quick strategies to consider. I know we've talked a little bit about some things to think about as you're working with your patients, but now in terms of preserving cognitive functions, what can you do as some strategies in your office for women with head and neck injuries? And honestly, here's just about 2 or 3 simple things that really are kind of big bangs for the buck. And it really starts with educating, enhancing the educational material and resources geared specifically for women. So women related brochures or pamphlets or parts on your website, anything that will help explain how that relates specifically to women. So definitely gearing it to, not just generally speaking, but helping women specifically understand. So again, female, brochures geared specifically to women outcomes. You could use a lot of the material that I presented here, as well as there's a link that you might want to consider. This is mostly developed for women in intimate partner violence situations, but that's a really great link to assess if you want to look at that. So you can easily create something in your own office as well. Definitely, we know that lifestyle modifications such as diet, social engagement, sleep are very important. So this sort of span not only just for women with head and neck injuries, but just really honestly the whole population is looking at a Mediterranean diet or the DASH diet. These are important with those antioxidants and lots of fruits and vegetables. It really has been shown to decrease risk of cognitive decline, dementia. And remember, that's head injuries are a risk factor for down the road. Social engagement is huge as well. Many times there's the fatigue. There might be some stigma and embarrassment of having the ability to recall memory, remembering the person's name you might have just met. A lot of times people will want to stay away and shy away from social interactions, but the more you can encourage and create that, be supportive and remind the woman that they really want to be able to encourage that social activity on whatever scale they can do significantly is a huge benefit to them to do that. And of course, sleep, because sleep is really, really needed. We get a lot of neural cleansing, consolidation of memory. A lot of things happen when we get, proper sleep, and a lot of things, go wrong when we don't have good, quality sleep. So again, anything you can do to help support sleep state, sleep hygiene is a good place to start. We're getting people off their screens and things like that, and the blue light night. So a lot of excellent education and support that you can give. And one final thought here is I'm really big on cognitive training and rehabilitative techniques that can be done. If you go back and look at some of the cognitive deficits that are seen, I listed some of the key ones here. Definitely these are going to be some of your main objectives that you're going to want to evaluate. And I'm a huge proponent on establishing in your practice an annual brain health assessment that could look in many different forms. It could be super, very simple. It could be a little bit more extensive and integrated. It just depends on your practice and how you're approaching all this. But really, honestly, doing that on a yearly basis and having a place where a woman can go have her cognitive functions evaluated, even if you want the brain assessment to be just the cognitive domain. But having something where there's that yearly documentation is a huge act of service. So that would be my wish to you. So just in conclusion there, hopefully that's been a nice little overview, continuing to really encourage that healthcare providers play such an important role in identifying and treating conditions and helping, create that cognitive capacity moving into the future, especially when brain injuries happen, that women's health, brain health and well-being is needed. And again, that routine brain health assessment is needed. So I've left you some resources at the very end, and if you need any more follow-up or questions, I'm always happy to help, answer any things that I might for any of the scholars on today. So thank you so much for allowing me to present this information.
Dr. Habanova, thank you so much for this excellent presentation. I'm going to do a quick summary and then a couple questions for you. So you talked about being receptive to your patient's desires to discuss cognitive changes as being a beautiful act of service, especially for women, and the impact of head and neck injuries. So the prevalence, females are underrepresented in TBI studies, and they found that worse outcomes in women than men in human studies versus animal studies, when comparing males to females. And rates and outcomes of TBI differ. So longer hospital length for females on average and more concussions for female athletes, more TBIs overall for pediatric male children, but specifically female athletes in comparison to male athletes. And neck injury as a comorbidity was more prevalent for females from puberty all the way up to menopause, and a greater risk of early onset dementia for females. If we look at that aging population, over age 65, females are more likely to have a mild TBI, and women are more likely to be institutionalized. Up to 94% of injuries for women sustain abuse from the neck and higher. So very prevalent, very, very important to start understanding the true impact of this. Brain injuries associated with negative learning, negatively associated with learning, memory, cognitive flexibility. And if we look to those imaging studies, we're showing deleterious effects of brain health with abuse. And TBIs are a major cause of lifetime morbidity, post-concussion deficits, high risk of dementia, higher hospitalization, and cognitive impairment after mild TBI. So the acute phase of TBI and at the 6-month follow-up, we found changes in white matter integrity, damage of the splenium and the corpus callosum, common to see hippocampus deficits, the ventral prefrontal cortex for decision-making processing in the default mode network, gray matter morphological changes, and overall impact of memory, cognition, immediate memory, delayed recall, episodic memory, executive function, verbal and visual memories. And then if we look at the molecular mechanisms there, we saw focal, diffuse. And so for focal, it can lead to secondary systemic complications. And if it's diffuse, which also leads to secondary systemic complications, that can lead to synaptic dysfunction, cell death, and axonal degeneration. And both lead to cognitive dysfunction overall. So decreased long-term potentiation and increased depression. And if we look at the deficits, again, common things that you will see with your patients, you definitely would want to have a checklist and go through a thorough case history for headaches, fatigue, sleep disturbances, dizziness, irritability, irritability, aggressiveness, anxiousness, depression, work or relationship difficulties. And then cognitively speaking, cognitive deficits, cognitive fatigue, executive function impairment, word finding, facial recognition of emotions, changes in mood, and less limbic flexibility. And I love how you mentioned the hormonal changes. So looking at the HPO, the hypothalamic pituitary ovarian axis, and the brain changes during the menstrual cycle. So we see a hormonal fluctuation. And we compared the follicular and the luteal phases. So the follicular phase, hormones are higher, better spatial skills, more responsiveness. With luteal, women tend to be a little bit calmer overall. However, we're not as good at recognizing fear. So this could be impacting executive decision making. And timing of the head and neck injury. So follicular versus the luteal phase. So with the luteal, we see if there's progesterone, we see actually a drop in progesterone with the TBI, which is worse for females because progesterone is neuroprotective. So when comparing females who have had a TBI during the luteal versus follicular phases, it's worse in the luteal. And also we saw better outcomes for women who are on birth control throughout the phases. And that was looking at the withdrawal hypothesis and identifying which if women were in the luteal phase. And then overall strategies for taking care of females, especially after suffering from a head or neck injury. Education, number one, enhanced educational material for women specifically. And then lifestyle, diet, sleep, and social engagement. So looking at the Mediterranean and DASH diets, social helps promote healthy cognitive aging, and sleep, consolidation of memory, and neurocleansing. If we look at cognitive training, we want to focus on attention, learning and memory, problem solving, executive function, affect and expression, and of course, integrating an annual brain health assessment. Such a wonderful presentation. Thank you. A couple of questions for you. As you look at the research comparing female athletes versus male athletes, we see that more female athletes tend to have concussion. We also, as you had mentioned, that females tend to have a longer rehabilitation time post-injury. Now, from your experience, would you say that it's, if you look at the research, it says that women tend to have weaker neck muscles. Do you think that it's due to weaker neck muscles, or do you think that perhaps or do you think that there's a consideration factor that in female sports, there's less expectation of being hit? So if you compare, for example, football, American football, men are wearing helmets and there's the expectation each time there's a play, somebody's going to get hit or tackled. So I was curious what your thoughts were on that and any pointers for us.
Yeah, that's a very good question. And in fact, when you look at the literature, it's a bit of a split decision there. You'll see some research that says, no, there isn't a significance between women's neck muscles in relation to their head weight and, and their development compared to men. Other research will say completely the opposite. So it's really what side of the fence do you want to sit on? I think you're right with boys football, right? They tend to have the helmets, and girls soccer is what is considered, the highest in the female sports of that age group. So definitely they're not wearing helmets when they're heading the ball and doing things like that. So we do know that whiplash and neck related injuries, in itself can cause a concussion. So there doesn't even have to be a blow to the head. There could be a blow to any part of the body, actually. So it doesn't even have to be a whiplash-like result of the neck. But there's been a lot of correlation between whiplash and concussion-like symptoms from a whiplash itself. So is it the whiplash? Is there actually something occurring in the brain in terms of a concussion there? So I really think you're going to have to just evaluate. Maybe some women have longer necks, and so you would think, yeah, maybe that is going to have a greater, biomechanical disadvantage, perhaps from an impact perspective. So I think it really is a case specific. But the literature, from what I've discovered, is really kind of sitting on two camps at this point.
Yeah. And then another question for you. A lot of women, when after being pregnant, they tend to report having mom brain, feeling like they have brain fog. Can you explain a little bit more of mom brain to us from a cognitive perspective? What's going on there?
Yeah, absolutely. So anytime there is anytime I'm actually in the process of putting another presentation together where we're looking at reproductive changes or hormonal changes. So, during a pregnancy, for example, and the menopausal transition right before menopause occurs. And at both times, the literature is showing that there is significant brain structural changes. So gray matter volume, as well as white matter. There is a change in glucose metabolism that goes down. So both times. So we really have to start looking at these, female-related, reproductive, hormonal things as not necessarily just to the endocrine system, but they're really actually neurological events. So even though there's changes to the hormones, like for example, after pregnancy, there is a significant sort of restructuring of the brain. And so these are really actually these are really actually neurological events. So, really coming back and revisiting the neuroscience of menopause, and that there is a lot of connection between brain health and, ovarian health or the neuroendocrine axis, and not forget that it's a neuroendocrine axis. So generally what you're seeing there in mom's brain is definitely changes in gray matter volume that does get restored post event. So when everything balances, that's true also for menopause. So as women are going through the transition where estrogen is rapidly dropping, similar to almost like a TBI with a progesterone, although that's a rather sudden impact. This can be a maybe 4 to 7 year transition. Then post pregnancy and menopause, there will be a leveling back up. So it's really almost just a temporary, and there'll be almost a brain resetting that occurs so that stabilizes and balances. But during that time is where there can be some challenges. So low glucose metabolism is occurring. So literally the brain is starving of energy, and there is definitely changes in the cellular structures that then reestablish down the road. So it's a real thing. So yes, we need to take that into consideration. What can we do as clinicians to support women who are going through these neurological changes or a neurological transition as they're going through those hormonal changes and shifts as well?
Wonderful. Well, thank you so much for explaining that to us and all the amazing work that you're doing, especially in female cognition. And as we
Thank you
wrap
so much.
up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Habanova for her excellent work in the field of pioneering functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.